تمام أستاذ. This is a 3 years old child presented for a pediatric hospital with failure of thrive and recurrent attack of epilepsy. This is multiple section MRI. This is the T1. And this is the axial T2 of the patient.
نعم.
This is the sagittal T2. The coronal. This is the contrast. Axial T1.
بس نرجع.
And this is the diffusion for the. العفو دكتورة، تريدين سيكونس معين؟
هو نرجع T1 axial. خلينا نكمل هذا
اوكي.
حسين، هذا مو ديفيوجن، هذا زيرو تايم ديفيوجن اللي هو حال التي 2. اذا عندك واحد غيره افتح هذاك اللي تشوف الديفيوجن. ماشي. خلي التي 1 بري بوست نفس السكشن، خلي اختار من فوق اثنين.
اوكي.
يلا بتقول ايش تشوفي ايش عندك؟
نعم أستاذ. MRI exam of 3-year-old boy, axial T1 and T1 post contrast. With T1 there is multiple high signal intensity subcortical lesion and أمشي دكتور شوية and subependymal nodule, multiple subependymal nodule و subcortical high signal intensity lesion. يعني اكو some of هي يعني high signal intensity بال T1 وال T1 post contrast، يعني ما اقدر اميز اذا كانت enhanced or لا. هنا السب ابندايمال نوديول. وبال T2 كانت low signal intensity، يعني كانه signal void السب ابندايمال نوديول، يعني it may show calcification. no hydrocephalus. يعني هذه البيكتشر يعني قد تكون tuberous sclerosis أو cytomegalovirus infection. cytomegalovirus infection يعني تكون more calcified lesion distributed throughout the brain parenchyma و brain atrophy وياها. أما هنا بس نشوف إنه هذه high signal intensity lesion subcortical و subependymal، no hydrocephalus, no brain atrophy. يعني البيكتشر most go with tuberous sclerosis.
من قلت هاي سيجنال in which sequence؟
استاذ هي انا شفتها بالتيتو ايضا، بالتيتو هاي السبكورتيكال.
لا السيجنال انتنسيتي مالتها قلتي هاي سيجنال انتنسيتي، احنا بالتيو عندنا تي 1 وتي 2 لازم we should specify which sequence high signal whether T1 or T2 or both.
استاذ السب ابندايمال هي هاي بالتي 1 ولو بالتي 2.
نعم. لا شنو الهايبر سيجنال اللي قلت عليها؟ قصدي هي النودل
هذه
وغيرها.
استاذ ما عندها اكو سب كورتيكال هاي سيجنال انتنسيتي بالتي 2.
اي
اي نعم.
اوكي you should specify. You should specify لانه مو بس هاي سيجنال وقبل.
نعم استاذ.
شكرا بتول. هويدا موجوده؟
نعم أستاذ صباح الخير.
هلا صباح الخير. هلا هويدا. ما هويدا شو تقولين؟
هو يعني picture of tuberous sclerosis، يعني نشوف أكو cortical زي ما قالت دكتورة cortical high signal intensity بالتيتو، وأكو عندنا هاي subependymal nodules اللي هي يعني subependymal tubers، حتى cortical tubers تمشي يعني.
منو ممكن بعد يصير عندهم دولة هو إذا بابا؟
هي association وياها giant cell astrocytoma.
صحيح. عادة وين المكان مالتها الجاينت سيل استروس؟
يعني بالسبتم يعني بالسبتم بيلوسيدم.
صحيح.
تسوي هيدروسيفالس، حتى ممكن البرزنتيشن يكون هيدروسيفالس.
زين تدزين على الطفل شو تسأليها؟
أول شيء سيجرز، لأنه الهيستوري يكون عندهم سيجرز.
الهيستوري مال السيجر.
mental retardation همين يكون عندهم، ويكون عندهم thin lesions.
اللي هي شو يصيحوا لها؟
والله أستاذ ما داري، بس هي سبير شيء فشي اسمه داري.
صحيح. عاشت ايدك.
احكي لنا على الكيس حسين.
تمام أستاذ. This is a 3 years old child presented with multiple attack of epilepsy to the pediatric hospital, and MRI done for her showing multiple subependymal nodule seen in average size about 3 mm. The largest one seen near the foramen of Monroe measure about 8 mm. The subependymal nodule are hypointense on T2 and hyperintense on T1, show no restricted diffusion and enhancement after IV contrast. Also, there is showing multiple cortical tumors, as this here, in multiple loops, and that are hyper intense in T1 and T2, no restricted diffusion and no enhancement of after IV contrast. This patient diagnosed as with the clinical history and this neurological picture diagnosed as tuberous sclerosis by Dr. Lamia Al-Attar.
And what is the main differential diagnosis of this tuberous sclerosis? Tubers.
دكتور يعني هو كان اكو سسبشن انه هي يعني viral infection عندها يعني ويا الهيستوري او congenital viral infection, but يعني النيورولوجيكال بيكتشر مالتها والفيتشر مالت الصب ابندايمال نودول ويا الكورتيكال تيوبرز ويا البرزنتيشن مالت الابيليبسي make the tuberous sclerosis the main diagnosis for the patient.
One of the important differential diagnosis of these tubers.
دكتور يعني اذا كانت larger size هي ممكن تكون giant cell astrocytoma وتمشي ويا the same diagnosis يعني.
مو giant cell. هاي التيوبرز هسه سبابندايمال تيوبرز هاي اللي مبينه هايبر انتنس بالتي 1 وهايبو بالتي 2. differential diagnosis قالتها فاطمه.
قصدك عمي مو السبابندايمال نودول، قصدك الكورتيكال تيوبرز.
ايه
العفو استاذ هذه
كورتيكال تيوبرز differential diagnosis والسبابندايمال همينه اكو differential diagnosis لها.
اي استاذ هذه ممكن هي يعني تكون ويا diffuse astrocytoma or infarction as this picture, but يعني الفيتشر together between the tuberous cortical tuber and the subependymal make the diagnosis in the way of tuberous sclerosis. يعني multiple finding.
Heterotopia حسين. Heterotopia the main differential diagnosis of these subependymal tubers. Sometimes تجينا subependymal heterotopia مالت هذه باعتبار المايجريشن يصير من السنتر للاوتر من الانر للاوتر. فسمتايمز تصير هيتروتوبيا همينه one of the main differential diagnosis او خلوها ببالكم. اوكي يا اذا تريد روح على شو اسمه على التوك مثل ما استاذ محمد قال لك. تفضل.
بسم الله الرحمن الرحيم. I'm Dr. Hussein and we will talk about the neurological feature of tuberous sclerosis. Tuberous sclerosis disease, also known as tuberous sclerosis complex or Bourneville disease, is genetically determined multisystemic hamartomas neurocutaneous disease. The organ most commonly involved are the brain, skin, kidney, lung, retina, and the heart. The diagnosis of tuberous sclerosis is divided into genetic testing and clinical criteria. The genetic testing identification of either tuberous sclerosis C1 or tuberous sclerosis C2 pathognomonic mutation is significant to make definitive diagnosis of tuberous sclerosis complex. 10 to 25% of tuberous sclerosis complex patients have no mutation identified by conventional genetic testing. The clinical criteria for the diagnosis are divided into major and minor features. Definitive tuberous sclerosis complex either two major feature or one major with two or more minor feature. Possible tuberous sclerosis complex, either one major or two or more minor feature. The major feature for tuberous sclerosis are angiofibroma 3 or more, non-traumatic inguinal or pre-inguinal fibroma, hypomelanotic macules, multiple retinal nodular hamartoma, cortical dysplasias, the cortical tubers or white matter abnormality, white matter migration line, subependymal nodule, subependymal giant cell astrocytoma, cardiac rhabdomyoma, lymphoangiolipomyomatosis, and angiomyolipoma. The minor feature for tuberous sclerosis complex are the dental enamel bits, 3 or more, intraoral fibroma, 2 or more, non-renal hamartoma, retinal achromic patch, multiple renal cysts. The main topic we will talk about today is the intracranial manifestation of tuberous sclerosis, and this is include the cortical tubers are benign hamartomas detectable in the cerebral cortex in approximately 95% of patients with tuberous sclerosis. 50% are in the frontal lobe, show high signal in T2 and low signal in T1, with only 10% of a tuber show enhancement, frequently calcify after 2 years of age. There are considered to be related closely to the neurological manifestation of tuberous sclerosis, and this is includes the epilepsy and the cognitive disability and the neurobehavioral abnormality. Lesion of the central nervous system alone are not diagnostic of tuberous sclerosis and may be seen in other pathological conditions. The cortical tuber on imaging on MRI typically appear as well circumscribed area of low signal intensity on T1 weighted image and high signal intensity on T2 weighted image sequence. As we see in this 8-year boy, there is cortical tubers showing by the white arrow, well circumscribed and high signal intensity. This is another picture, T2 weighted image show cortical tuber well circumscribed with high signal intensity. The second important intracranial manifestation of the cortical tuberous sclerosis is the subependymal nodules. Are common brain lesion found in patients with tuberous sclerosis, which represents hamartomal growth, and it is usually smaller than 1 cm. This is the measurement is important because we differentiate between subependymal nodule and the giant cell astrocytoma mainly by the size of them. 88% are associated with calcification, although calcification absent in early childhood, visible with the first 6 months of age, show variable signal, frequently high in T2 and ISO to high in T2 weighted image. Enhancement is variable, and it is not useful feature in distinguishing them from the subependymal giant cell astrocytoma. As we said, the size is more than the enhancement. On CT, the CT scan is useful for detection of subependymal nodule as they associated with calcification. MRI, subependymal nodule show intermediate signal intensity on T1 and ISO to hyper intense signal on T2 weighted image. This is an axial CT scan without contrast, so show multiple subependymal nodule with calcification, as we said. And this is another axial T1 MRI, show ISO intense subependymal nodule multiples. The third important intracranial manifestation of tuberous sclerosis is the subependymal giant cell astrocytoma. SIGA are widely accepted to be derived from subependymal nodule. The progression is generally good as SIGA growth slowly, and it is usually larger than 1 centimeter. And as we said, this is important to be differentiated between subependymal nodule and subependymal giant cell astrocytoma. However, SIGA may be symptomatic or asymptomatic. Maybe growth result in ventricular obstruction and hydrocephalus. SIGA are hypo to iso-intense compared with cortex on T1 weighted image and heterogeneously iso to hyper on T2 weighted image. Peak occurrence are 8 to 18 years, tend to be larger and demonstrate growth, also tend to have intense enhancements after IV contrast. This is a FLAIR axial image show heterogeneously enhanced mass. This is the mass. Oh, this is subependymal giant cell astrocytoma in the frontal horn, bilateral ventricle near the foramen of Monroe. This is the axial T1 enhanced image after IV contrast, showing strong heterogeneously enhanced lesion. This is the subependymal giant cell astrocytoma. Another manifestation of tuberous sclerosis is the white matter abnormality. White matter abnormality in the tuberous sclerosis include superficial abnormality associated with cortical tubers, radial migration line, and cyst-like white matter lesion. On MRI, superficial white marrow abnormality are seen as hyperintense area on T2 weighted image and hypointense on T1 weighted image. This is a FLAIR axial section showing the superficial white matter abnormality as hyperintense area in relation to tubers. This is the white matter abnormality here. And also there is another rare finding for tuberous sclerosis disease may include, but these not specific, these are the cerebral atrophy, infarction, cerebral aneurysm, dysgenesis of corpus callosum, Chiari malformation, microcephaly, arachnoid cyst, or chondroma. This is the reference of our lecture today. And if there is any question, and thank you for